Here's just diffuse subarachnoid hemorrhage. It's just a thin layer over the entire surface of the brain. Subarachnoid, the most common reason you get it is head injury, trauma, but there's many, many other reasons you can get it as well. And we'll talk about a few of those later. For radiology, there's basically three things we see at autopsy. Commonly, the autopsy confirms whatever the imaging findings were. So they'll say, we scan the child, they have subdural, and then we confirm it. But very commonly, we'll identify a hemorrhage that was not seen on imaging. So they might look at the brain and say, well, the brain's swollen, but we don't see anything else, and then we see a subdural. And then sometimes, the autopsy will not identify something that was seen on radiology. So they say, yes, this child's got a big subdural. When we get in there, there's nothing. And that's okay. In fact, I prefer it to be that way because it's okay if we start out saying this is possible abuse and then work our way back to not being. But I hate to miss something. So overcall is okay. But there are just times that you see things radiographically that don't have an anatomic correlate. Sometimes thin layers of subdural are going to be missed. Subarachnoid blood, I think, is very difficult to see on imaging. Other things can masquerade as blood. So I've seen kids with a raging meningitis that were initially thought maybe to be abuse, just because they had a layer of what ended up being basically pus over the surface of the brain, but on imaging it looked like blood. So that can happen as well. And all of these things will continue to improve as the modalities for imaging improve. Autopsy's autopsy. It's not really going to improve much more, but we can still have more correlation. Ocular findings, we've talked a little bit about retinal hemorrhage, retinoschisis, which is splitting of the retina. There's also optic nerve hemorrhage and soft tissue hemorrhage around the optic nerve, so coming out of the back of the eye. Oftentimes you might hear people talk about Tierson syndrome, which is basically retinal hemorrhage in kids who have just a big swollen brain. So they have increased intracranial pressure and they get hemorrhages associated with that. It's pretty common. I see kids all the time that have retinal hemorrhage that have not been abused. However, if they have raging, super enormous retinal hemorrhage, you do have to ask, well, what's going on with this kid? And again, you have to correlate that with the clinical history and the entire picture. The problem with retinal hemorrhage is that it has been wildly overused in the past. I've seen cases, the most egregious example, and I don't remember where this was, but I read about it, was a girl who was in a car wreck, massive car wreck. She sustained massive head injury, goes into the hospital, they're working her up for the head injury. The ophthalmologist comes in and says, oh, you know, she's got retinal hemorrhage. The interpretation was she was abused and shaken, placed in the car, and then had a car wreck. And that's just garbage. So there are times it is overused and overcalled. You've got to take the whole scenario into consideration. In the retina, there are layers, so we talk sometimes about the location of hemorrhages within the layers. Is it in the outer, middle, or inner layers? What do they look like? Are they little dots? Are they flames? And where are they located? A lot of people will say if they extend all the way out to the sides of the eyes, that's more likely to be abusive than not. Although, again, I've seen plenty of examples of major retinal hemorrhage that were not abusive. We've already seen a picture of this. Here's the retina. Here's what it looks like under the ophthalmoscope. These little blots of hemorrhage. At autopsy, again, I get to do things that pediatricians can't do. We just take the eyes out. And this I show because it's a negative one. There is some hemorrhage around the optic nerve, which actually was from blood tracking. There was a subdural that sort of tracked inward. But the retina itself is completely negative. And then to show you what a positive looks like at autopsy, these are multiple hemorrhages. This was an abusive case, but that's what we're looking for. We will try to section those as well, look at them underneath the scope, and try to date those as well. But typically, as Dr. Dina said earlier, if it's really bad, they're going to have vision impairment and other problems. I mean, so if the history is that they're fine and now they have this, you know, they haven't been walking around with it for weeks. A couple of other things about this. I'll just tell you that depending on who you interact with medical examiner-wise, some medical examiners put a lot of weight in retinal hemorrhage, others put none. So you need to know who you're working with and what they feel about it. I've had some people go so far as to say, and some of my colleagues say that they don't even bother taking the eyes anymore because it doesn't push them one way or another in a particular case. And I kind of agree with that. There's never been a case I've ever had where I'm like, oh, it might be abuse, and then I look at the eyes and change my mind one way or the other. I think I still do it. I still collect it because it's another point of data, but I'm not ever going to hang my entire case on that. So be aware, you're going to have some jurisdictions where they put a little weight on this or don't even look at it anymore. Neck injuries is something newer that's coming into play, both from the radiology perspective and the autopsy perspective. The reason this sort of has started up lately is because there are the whole camp of individuals, or experts, quote unquote, who say you cannot shake a baby to death, period. And they base that on a lot of biomechanical studies and other things. And one of the things that they always claim is that based on models, they don't believe you could sustain a brain injury from shaking alone without having a neck injury first. They say all this whiplash-type movement should have caused something in the neck, but we never see neck injuries. And so the question that's been asked more recently is, do these kids never have neck injuries, or are we not looking for them? Because it's a very difficult area to look at. So radiographically, they're starting to look for some things. Soft tissue edema, especially the back of the neck, or swelling. Sometimes I get reports of that now when I'm working up a case. I'll see that in the radiology report, that they see some swelling that might be related to a neck injury. That's really difficult to verify at autopsy. If I see something broken, I see hemorrhage, whatever, that's easy for me to verify. But just saying that a muscle is swollen, you can't really talk about that at autopsy usually. On the other side of things, from the pathology side, we've started looking at cervical nerve root hemorrhage, which might be an important finding too, but the problem is you can't image it because it's too small. So we have one finding that the radiologists have and one finding the autopsy has, and we can't correlate either one yet. So we're still trying to figure that out. And I'm going to talk about that more in a little bit. We're going to go into abdominal trauma and then later come back to neck and subdurals and that a little bit more because I kind of cover that as a separate controversial topics part. But abdominal trauma, I think, at least in the cases I've done, is a much more difficult workup because these kids can, depending on how bad their trauma is, they can be walking around for days, slowly getting worse. Now, you're going to have some kids that have horrible, horrible injuries. Their liver's been torn in half. They're going to go down very quickly, decompensate, and die. You don't tear your liver in half and just walk around. But I've seen other kids with small tears of the bowel, small tears of the mesentery, we'll talk about some of these structures, who literally for a couple of days have kind of been getting worse, maybe not eating very well, and then finally die. And the reason this becomes so difficult is that at trial, of course, the lawyers want us to pin down the exact time frame. The baby was with this person at this time. Yesterday, the baby was with this person. 2 days ago, they were with this person. Who did it? And we might not be able to answer that. So let's talk about it. The things we typically see internally are lacerations of tears or transections, just complete splits of midline structures. So the liver, the pancreas, duodenum, everything that is in between that fist or that foot or whatever, and the vertebral column. They all get squashed in between. We also see a lot of tears of the mesentery, which is basically the soft tissue that just sort of holds the intestines in place and kind of tethers it in place. Here's a child that I would imagine most of you, even not being a pediatrician, would notice that that abdomen is really tight and tense and kind of shiny. The story in this case was she was fine and I found her unresponsive on the sofa. When they got in, she had a tear of the liver. She had a lot of inflammation inside the abdomen. Something horrible was going on. There were tears of the mesentery. So this is the stuff, again, that holds the kind of guts in place. And this as well, I think this was a different case, but this is a complete transection of the duodenum. So to get you oriented, basically the stomach would be up in the right-hand corner. The stomach dumps into the duodenum curves around this way, it keeps going this way, but in this case it curves around, stops, and then starts again. So basically everything this child would put in her belly, in her stomach, would just dump into the abdomen, and it wouldn't continue down the intestinal tract. So again, all midline structures. Here's an injury of the liver. This is a lot of sort of lacerations of the liver on the underside of the liver. So again, these can be really complex cases depending on how bad the injury is. The other thing that they will commonly use as a defense tactic in this will be CPR-related injury. They'll say, oh, well, they were giving aggressive CPR, and that might have torn the liver or something like that. So my recommendation, and I say this over and over, is when it comes to CPR, ask who did it, how did they do it, who administered it, how long did they administer it, all these things. Because they will try to argue on the stand that, well, mom doesn't know CPR, she was just pounding on the kid, and maybe she didn't know where to put her hands. Now, I mean, anybody watching TV knows you put your hands over the chest, not the abdomen, but that's what they're going to argue. There are a couple of good references out there that talk about that it's very uncommon for children to sustain real, true CPR-related injuries. They're rare. A couple of things in the trachea and stuff if you're intubating, maybe an occasional rib fracture. I've never really seen good documented abdominal trauma like this from CPR. And if you have, we can talk about that. So, but she says, ooh. Anyway, extremities, we've already talked about a little bit. Again, I have the ability, if I need to go in and physically remove a bone and look at it. I don't like to do that in the extremities. It seems like that's sort of the tipping point where people